Ashkan Shoamanesh and Mike Gibson coming to you live from ESC 2022. And we're talking about the Pacific Stroke Trial, an exciting new trial looking at factor 11 inhibition. You heard that right, not factor 10, but factor 11 inhibition in stroke patients. So Ashkan, talk to us a little bit about why you did the study.
Sure thing, and thanks very much for the opportunity to speak to you today, Mike. First, there's a large unmet need in the target population here, which was patients with non-cardioembolic ischemic strokes. These patients have a substantial risk of recurrent events, that's over 6% per year. And current guideline recommended treatment includes either single antiplatelet therapy, sometimes with a short duration course of dual antiplatelet therapy, depending on the subgroup. Anticoagulant therapy has never been established to assist in improving stroke prevention in this population. However, in the COMPASS trial that many of your viewers are probably familiar with, dual antithrombotic pathway inhibition with a factor 10A inhibitor, rivaroxaban plus aspirin, resulted in a substantial reduction of stroke in patients with systemic atherosclerotic disease.
About a 45% reduction. I mean, it was very impressive, right?
Very, very large effect size. And of all the vascular events, actually ischemic stroke was most greatly reduced. And this seemed to be generalizable to different stroke subtypes that occurred during study participation. So we were interested in looking at dual pathway inhibition for targeting optimization of secondary prevention in patients with non-cardioembolic ischemic stroke. Now, with the novel factor 11 inhibitors, there's a really exciting opportunity to address this need. As you know, these agents are believed to have reduced bleeding complications because although factor 11 and activated factor 11A is key for propagation of clot and pathologic thrombus formation, it has a lesser subsidiary role in hemostasis. So the hypothesis is that we can prevent thromboembolic events without an associated increased risk of bleeding. And there's been some very exciting phase 2 results in the realms of total knee arthroplasty, prevention of VTE, as well as a safety signal that surpasses that of apixaban in patients with AF that has been seen to date with these compounds. So to basically confirm or at least support this hypothesis. More interestingly, for patients with stroke, is that we know from epidemiological literature that patients with ischemic stroke have higher levels of circulating factor 11, and that those that have inherent factor 11 deficiency have lower rates of ischemic stroke compared to the general population. So on the basis
as venous events as well, both, right?
Correct. So on the basis of this background information, we designed the Pacific Stroke Trial, which is a phase 2 prospective randomized placebo-controlled dose ranging study looking at 3 doses of asundexian, which is a small molecule direct inhibitor of factor 11A, 10 milligrams, 20 milligrams, and 50 milligrams daily. And those doses were compared to placebo on top of background antiplatelet therapy. So this is something that's kind of a bit unique to this trial relative to, for instance, the Pacific AF study, because we're testing the use of asundexian on top of background antiplatelet treatment.
Great. And what did you find?
Yeah. So in patients with non-cardioembolic ischemic stroke, which were within 48 hours of symptom onset, we found that treatment with asundexian did not lead to a dose-dependent reduction in our primary outcome that was the composite of ischemic stroke and covert brain infarcts on MRI. This was the primary analysis. It was a dose-dependent response, and that was insignificant. However, 2/3 of the primary outcomes were small, covert subclinical infarcts that were only detected on MRI. And when we divided the components of the primary outcome, we found absolutely no effect on the outcome of covert brain infarcts on MRI, which are typically due to a different underlying pathology or small vessel disease, which one can very reasonably hypothesize it may not be as responsive to factor 11 inhibition. For the component of the primary outcome that was ischemic stroke, there was a notable trend for a 20% risk reduction with asundexian 50 milligrams daily versus placebo. We were also very interested at looking at the subgroup of patients who had atherosclerotic disease contributing to their stroke or markers of systemic atherosclerotic disease on the basis of the COMPASS trial that we discussed earlier. And very interestingly, in this subgroup of patients, asundexian 50 milligrams in particular led to very large effect sizes for the reduction of ischemic stroke. And in particular, there was over 40% risk reduction in the composite outcome of ischemic stroke in TIA and post hoc exploratory analysis. And in those that had atherosclerosis noted on imaging of their arteries, either within their neck or in their brain or the arch, there was actually a greater effect size of over 50% reduction in the outcome of the composite of ischemic stroke and TIA. So we're actually very interested in this signal that was identified in post hoc exploratory analysis, but there's quite a bit of a priori literature that supports it. And we think it's a very exciting signal to explore further in a phase 3 trial. I'll also mention that consistent with the hypothesis that you do not have an increased risk of bleeding with these agents, we did not see any statistically significant increase in our primary safety outcome, which was a composite of ISTH major bleeding or clinically relevant non-major bleeding, as well as no statistically significant increase, and actually no numerical suggestion thereof for all bleeding. And for stroke neurologists, one of the greatest concerns when you're adding an anticoagulant early after an ischemic stroke is hemorrhagic transformation or bleeding into the vulnerable brain tissue that's been infarcted. And we saw absolutely no suggestion of an increase in hemorrhagic infarction in patients who received asundexian on top of antiplatelet therapy. And these patients were randomized within 48 hours of their stroke. So this is all very exciting and reassuring data that needs to be explored and confirmed further in a phase 3 trial.
Do you feel like you have enough data and enough patients to make a decision about the right dose for further testing?
Good question. I should have mentioned that there's total sample size here was 1,808 patients, and they were recruited across close to 200 sites in 23 countries. So we do have a large global population and close to 450 patients in each arm of the study. So we do feel that we do have the adequate power, and we've seen statistically significant results in our exploratory analyses. And combining that with what we know about factor 11 levels and their association with stroke in the general population.
Well, that was going to be my next question, is did you do PK/PD, and did you see a relationship between PK/PD and outcomes?
We have not looked at PK/PD or done any further analysis in that regard in the Pacific Stroke study. What I can tell you is that the PK/PD data, as far as the degree of factor 11 inhibition with the individual doses of asundexian, were very similar to what was published in the Pacific AF paper in the Lancet, where essentially asundexian 50 milligrams daily leads to near total inhibition of factor 11 levels.
So knowing that, do you feel like you're going to go towards that higher level of complete inhibition? Is that going to be the goal with this class, do you think?
So there will be a press conference led by Bayer on August 29th, where we will discuss any potential for a phase 3 study and what dose will be looked at. However, based on the data that we've seen, the most promising one looks like the higher dose of asundexian 50 milligrams daily.
Great. Well, thanks for joining us. Thanks for sharing with our audience. And thanks to all of you for joining us here live from ESC 2022.